This video is aimed at all clinical staff involved in stabilisation of critically ill children in the acute hospitals of Yorkshire and Humber. It's for medical, nursing and allied health professionals, working in paediatrics, emergency departments and anaesthetics.
Hello, I'm Ram Thomas, one of the clinical leads of our Yorkshire and Humber Paediatric Critical Care Operation Delivery Network. We've prepared a podcast on bronchiolitis for our doctors in the region. We haven't seen much bronchiolitis in the past year, and experienced clinicians have told us that they would benefit from a refresher. And there are many amongst you who are new to pediatrics or have perhaps worked in pediatrics for a year or a little over a year and have not had the chance to look after any babies with bronchiolitis. We're expecting to see a surge starting from August through to winter, as you see, and this modelling is based on data from elsewhere and the current rise in respiratory viruses in our country. So this is the outline of the talk. I'll do respiratory failure and recognition and when to worry, and a little bit about high flow oxygen therapy and CPAP. Sean Cooper, my colleague from the North, clinical lead from the North, will talk to us about resuscitation, stabilization, when to intubate babies with respiratory failure. And Mark Winton, who's in his last year of pediatric intensive care medicine training, will speak to us about packaging and preparing a patient for transfer. Alongside, we'll also signpost you to some guidelines and resources and checklists which are useful and just give you practical tips. So the first section, recognition of respiratory failure. So the key thing is to have a systematic approach, as we always do, and look for warning signs of deterioration, both in the clinical history and in the clinical examination. Look for those red flags that are heralding decompensation. Monitor closely, watch the trends, and also be aware of the pitfalls in diagnosis and management, which we'll come to later. So when considering in the history, think about the temporal profile of the illness. That is, we know that bronchiolitis is a self-limiting condition, usually lasts for 3 to 7 days. So consider if it's the 6th day of illness and the baby isn't getting much worse, and the baby is over the worst of the illness, they're probably going to get better, not worse. And if the baby is progressively getting worse, and this is day 2 of the illness, and they're looking quite unwell already, there is a likelihood that they will get much sicker. So fever is usually low grade in RSV bronchiolitis. If it's high fever, suspect bacterial infection or adenovirus infection. So when looking at the respiratory rate, the rate rises as babies get sicker. It's the respiratory distress to think about, the work of breathing. Be mindful that ex-prem babies with soft compliant rib cages may have more severe indrawing of the ribs when they have respiratory distress. The important thing, the red flag for me, is irregular respiration or pauses, or when the respiratory rate starts slowing, then I would worry, because that means the baby is getting tired. Also, if the baby is working so hard that they're not able to feed, then worry that they may be getting worse. In the cardiovascular system, often if babies aren't feeding enough, they won't be making much urine, there won't be very many wet nappies. A change in color to pale or blue is worrying, and as is when babies get cold and clammy. That means they're just decompensating from a cardiovascular system point of view. Babies who are looking around and alert, they're usually reasonably well. If they're agitated, whingy, drowsy, looking tired or vacant, then that could well be hypoxia or hypocarbia, and they're decompensating. Also to consider in the history are the risk factors. Now, very tiny babies have smaller airways, smaller bronchioles. Preterm babies who have chronic lung, or babies who have chronic lung disease will have fewer alveoli. They may have had ventilator-induced lung injury, so lower surface area for gas exchange and a bit lower baseline function. Also consider the babies who have a left to right shunt or hypoxic conditions are also at risk of getting quite unwell. So in the clinical examination, as we talked about, so I wouldn't worry if they're alert and able to feed. Always make sure we monitor them closely and watch the trends. I would be concerned if they were beginning to look sicker. We've got some signs here listed here, and red flags if they're looking exhausted, if they're having apneas, if they're looking as if they're compromising C and D. I would worry. So clinical management is mostly supportive and close observation. There are many things we can do to optimize respiratory function, as in you can lie the baby head slightly up, make sure we suction the nares to unblock, mucus plugged nostrils. Laying a baby prone often helps. Also, if the stomach is full with, NG with enteral gastric feeds every few hours, it can press upon the diaphragm and cause respiratory compromise. So often we might choose to reduce feed intake or substitute enteral feeds with IV fluids. Helpful in deciding about whether to intubate or not, but is useful to rule out pneumothorax or collapse of lung collapse, subsegmental collapse secondary to mucus plugging if there's a sudden deterioration. So other things to think about is babies with chronic lung disease, as we said, often have a low baseline lung function. So they may have a baseline high CO2. We usually accept lower saturations in these babies and have a higher threshold for intubation because their baseline is set differently to babies who are normally healthy. The other thing to keep in mind is a subsection of these babies have pulmonary hypertension, and hypoxia or hypercarbia may provoke a crisis. So these babies also, you may find that sometimes we set threshold for, we aim a little lower, we aim for high oxygen saturations, and we try to avoid triggers for pulmonary hypertension as listed below. Often bronchiolitis coexists with a cardiac condition, or it could be a cardiac condition masquerading as bronchiolitis. And these are some clinical signs for cardiac diagnoses. Also keep in mind that if you have a baby with extreme tachycardia, they may be having tachyarrhythmias. Keep in mind congenital heart diseases with left to right shunts, volume overload, left coronary artery arising from pulmonary artery. These two groups of patients usually present, as a pulmonary vascular resistance falls around the 5 to 6 weeks of age. A rare differential diagnosis is myocarditis, cardiomyopathy. So management of cardiac conditions is fluid restriction and judicious use of diuretics. Try to make a diagnosis and then move on. So this is something also that you can sometimes see, neurological diagnosis masquerading as respiratory failure. So there's apnea but no other significant respiratory symptoms, or the baby is looking alert and as apneic. So hypotonia. So they're not tired, but they're central apnea. So I've seen an example is infant botulism masquerading as bronchiolitis, was intubated for apneas and thought to be bronchiolitis. The baby had botulism. Spinal muscular atrophy is another one that I've seen presenting as thought to be bronchiolitis, and actually they just had mucus plugging and they had subsegmental collapse of their lungs and went into respiratory failure. Also note that babies with neuromuscular weakness may not have increased work of breathing, and because of their neurological function being what it is, they are prone to mucus plugging atelectasis. We try to avoid thickening their saliva by giving anti-sialagogues because they may have mucus plugs, and be aware when they get exhausted, it may not be that obvious. They don't have increased work of breathing, so these babies need careful monitoring. Position them carefully, try and optimize their oropharyngeal toilet, and physiotherapy may be beneficial. So we have a lower threshold for starting respiratory support for this group of babies because otherwise they just get exhausted and we'll be doing it in a hurry. So this section on high flow oxygen therapy has been prepared by our ODN educator Sam Burns. She has much more detailed presentations. This is for for a nurse education training, and this is modified from that section that she has prepared. So high flow nasal oxygen therapy is, I think of it as CPAP light. So it washes out CO2 and it provides a reservoir of oxygen in the upper airway, and it provides some as yet undefined pressure, distending pressure to the lungs, which is not really reliably measured. So these are the things to think about when we consider whether we should start high flow oxygen therapy or CPAP. There's some indications here and some warnings, cautions, and contraindications. And do think about it carefully, because high flow oxygen therapy is not really a substitute for nasal cannula oxygen. It provides a bit more support than that. It is more comfortable than CPAP, so that's an advantage that we'll come to in a bit. This is some guidance on the weight bands and the amount of flow you may use for when you start high flow oxygen therapy. Your individual trust will have guidance on this with the equipment you use. So as we'd alluded to earlier, careful monitoring, keeping an eye on the fluid balance, suspending feeds if the baby is looking particularly unwell. But once they're stable, it's better to feed them, because that'll give them some energy. And also if they're hungry and agitated, then they won't cope so well. And they use up more energy trying to breathe then, and they can have worsening respiratory distress. So also note that when we feed them, when you restart feeds, they may just make sure that they don't deteriorate. You may have to cut back on feeds and balance very carefully between how much fluid to give and how much enteral feed to give. So we often go from bolus feeds to continuous feeds, so that the stomach is not distended. So this is comparisons between high flow and CPAP. High flow is generally more comfortable for babies. There's some babies who just will not tolerate the seal of a CPAP mask, and the discomfort that it sometimes gives. And you often find that you can manage better with high flow. There's a low risk of nasal trauma, and it's easier to sort of access the baby. It's just not as noisy too. But as we said earlier, that we don't really know how much pressure we're delivering. And the other thing to keep in mind is if you're nebulizing, if you're trying to deliver a drug via a nebulizer, you really can't deliver it via high flow oxygen therapy unless you have a specific device called an aerogen, which you can fit to some high flow devices. Remember, you may have to stop giving the high flow oxygen whilst giving a nebulized drug driven by oxygen. There are some potential complications, but they're rare. So in short, we've been through a recognition of respiratory failure, how to manage basic things, how to manage bronchiolitis, and the next section will be on resuscitation and stabilization, when to intubate, ventilate, and some practical tips on intubation and stabilization of babies with bronchiolitis. Thank you for listening. The notes in accompanying the slides have further information, so it's worth a look, because I may not have said everything that's in the notes. Thank you. Bye.
I'm Sian Cooper, and I'm the clinical lead for the North for the Yorkshire and Humber Paediatric Critical Care Network. During this part of the talk, I will cover intubation, when, how, and what to do if things don't go to plan, ventilation, some basics and tips for troubleshooting, stabilisation, the main priorities, and I'll introduce some useful links. Embrace and Children's Intensive Care often get calls for advice on when a child should be intubated. In acute respiratory failure, these are the main reasons a child might need intubating. Hypoxia in at least 60% oxygen, severe respiratory distress, apnea or bradycardia, significant acidosis which is not improving to initial measures, a Glasgow Coma score of less than 8, or if the child is peri-arrest. The indications are the same for a child who is on non-invasive support and not responding. We're happy for local teams to make the decision to intubate and proceed, but it can sometimes be more difficult to decide in a child with complex problems. We're also happy if you're not sure to get advice. Call Embrace for a conference call with the paediatric intensivist. So why are children different to adults? Well, they can be more difficult to intubate because they have a larger tongue and occiput and they have a short neck. The larynx is anterior, so positioning is important. They have a big floppy epiglottis and a short trachea, so the ET tube can quite easily go down the right main bronchus. In addition, their cricoid cartilage is the narrowest part of their airway, and they have in general smaller diameter airways. So these airways have high resistance and they're quite prone to getting blocked. That's not to mention the behavioural differences. Sick children are scared, they don't understand what's going on, and their parent or carer may or may not be present for reassurance. If you've made the decision to intubate, always have a plan. And that's not just plan A, but plan B and C. It's really important to gather all the right people together before you start. Know your advanced paediatric life support guidelines. In my own unit, we hold a pre-brief to talk about what the problem is, what to expect, what the plan is for deterioration, including cardiac arrest, and role allocation. Use an intubation checklist. All hospitals should have these. Embrace will have one if you can't lay your hands on one. Have an app on your phone with resuscitation algorithms. The iResus one is really good. When you're preparing, there are lots of things to consider, and I'm just going to touch on a few of them. Pre-oxygenation is so important because children can decompensate quickly. And tidal CO2 monitoring is essential from the start. I will talk more about endotracheal tubes in a minute. For children, you can use a curved blade above the age of 6 months. Below that, it's a straight blade laryngoscope. For induction drugs, we usually recommend ketamine for cardiovascularly unstable patients or small infants, or propofol for cardiovascularly stable and older infant and children. Of course, we want you to use what you're familiar with. Many of these children will need a rapid sequence induction, and we now recommend rocuronium for muscle relaxant. Fluid bolus ready is a definite. Inotropes should be ready or on if the child is cardiovascularly unstable, but this is often not needed in many acute respiratory failure patients. You must plan for an unanticipated difficult airway, a failed intubation, and even cardiac arrest. And don't forget to utilise your video laryngoscope, which most hospitals should now have available with a paediatric blade. A bit about ET tubes. Size guides are available for the internal diameter and the length of tubes on the Embrace website, in your APLS manual, and in many of the apps that are available for phones. You may choose a cuffed or an uncuffed tube. Cuffed tubes are useful because if your first tube has a large leak around it, then this may save you from upsizing the tube. Don't forget to choose one size down if you're going to put a cuffed in. Oral versus nasal tubes. Well, I would always advise going with an oral tube for your first attempt. Nasal tubes are a little bit better tolerated and more secure for transport, but we do not expect this as an essential If you are comfortable and confident to change your oral for a nasal tube, then that is your choice. We tend to secure ET tubes in children with the Melbourne strapping technique, which Mark will show you a picture of later. And one thing I would ask is please don't pre-cut your tubes, because we can find that occasionally this can be too short and the child will need reintubating at a later stage. Don't forget to put an NG tube in at the same time, because decompression of the stomach can make a massive difference to ventilation in a child. Now we come to ventilation and oxygenation once your ET tube is down. This might cause some problems initially, so what I want to talk to you about is firstly getting started and then troubleshooting problems. Don't forget to use a heat moisture exchange filter. When you get started, think about the compliance of your circuit and minimise the dead space. It's fine to use pressure or volume control in an infant or child. We normally aim for tidal volumes of 5 to 7 mils per kilo. I would say aim on the generous side to start with, because you've probably got a little bit of recruitment and catching up to do. Use whatever peak pressure is needed. It may need to be high initially to open up the lungs. I would always encourage use of PEEP. 5 is a minimum, may need 8 to 10 in severe respiratory failure. And use a physiological respiratory rate, so about 30 in infants, going down to 25 or 20 in older children. The eye time you can usually set at about 0.8 seconds for small infants, going up to 1 second for anyone else. You'll be using your standard anaesthetic monitoring guided by the saturation and the CO2, and use gases to correlate here. Arterial gases are not essential unless you've got severe hypoxemia. When you're not winning, always go back to basics, so ABC. Remember the DOPE acronym, which is displacement, obstruction, pneumothorax and equipment. So check the tube is in the right place, not down the right main bronchus. Check the tube isn't blocked. Check for tube leak. The tube may need upsizing if this is the case. Exclude a pneumothorax, and check the NG tube is draining air from the stomach. Don't forget to check your equipment as well, and check that the child is adequately sedated and muscle relaxed, because sometimes sorting this out can really help. In terms of ventilation, if you have a problem with clearing CO2, there's a few things you can try. Bagging and suction, increasing the peak inspiratory pressure or respiratory rate, and reducing the dead space, so seeing if you can take something out of the circuit. If you have a problem with oxygenation, so hypoxia, again, bagging and sucking can help. Often the tube can be partially blocked, or there's some secretions down there that just need to come out. You can increase your PEEP or your eye time, and sometimes increasing your PIP as well may help. When you're initially stabilising an infant or child, sometimes they do need quite high pressures in the high 20s or low 30s initially just to open them up. And this can then be brought down later when their gases are improving. And don't forget to reassess frequently when you're making all these changes. So just a little bit about stabilisation. Good paediatric critical care, in my view, is about getting the basics right and attention to detail, so it's all about A, B, C, D, E. As well as focusing on airway and breathing, you need to get these things done quite early. 2 good working IV accesses are the minimum. Treat shock if it's present. You will need full sedation, analgesia and muscle relaxation to help you manage these patients and optimise ventilation, so this needs to go in quite early. And Mark will cover in more detail later what drugs we like to use. The Paediatric Critical Care Society in the UK have some really great training videos on practical procedures in children. This includes arterial lines, central line insertion including internal jugular, chest drains, intraosseous line insertion, changing an ET over a bougie and nasal intubation, ET tube taping, tracheostomy tube changes and running through transducer sets. And all the network guidelines are easily accessible via the Embrace website or via the Yorkshire and Humber Paediatric Critical Care ODN website.
Hello, my name's Mark. I'm one of the doctors working at LGIP ICU and Embrace. And I'm going to finish the talk by discussing preparing a patient and packaging them for transfer prior to the Embrace team arriving to move the patient to a paediatric intensive care unit. I'm going to talk through things in a to E fashion and then talk about some admin at the end. And we're going to presume that the patient's now intubated and ventilated going forwards from their respiratory deterioration. So considering the airway, the key thing for us to know is the ETT, the endotracheal tube, in a good position, and is it secure, and have we documented where it is at the incisors or at the nose if they've been nasally intubated. And we know that in infants and children, sizing and inserting an ETT at the right length can be a challenge, especially in an acute situation. And we know that small degrees of difference in terms of a couple of centimeters can make all the difference for our patients. Here we can see patients have been intubated and the ETT is too far in, it's down the right main bronchus, meaning that the left lung is not being ventilated and the right lung is being hyperinflated, and that is not going to be good for our patient going forwards. Here the opposite has happened. The ETT is very high and is at risk of coming out and having an accidental unplanned extubation, I should say, which will put your patient at a significant amount of risk. And here the ETT is just right, and we're looking for the tip of the ETT to be at T2, the second thoracic vertebrae on chest film, and that's the ideal position that we're looking for, and we want to look at that before we move our patient onto our transport trolley and off to the PICU. This table is taken from the Embrace drug chart, and it's a really handy sizing guide. It's not absolute every time, but it's a useful guide to think about what size of ET tube you should use and where it should be at the lips or at the incisors. And it's worth noting this size is for uncuffed tubes. We like cuffed tubes as well, so just go for the half size smaller. But it's worth thinking, if you know you've got a 2-year-old and they've got a 4.5 ETT in, and at the lips it's at 15 centimeters, then we can be confident that's probably too far in and needs readjustment after the chest film. In terms of securing the tube, we use modified Melbourne strapping using 2 elastoplast trouser legs to secure our ETT. And that might be different to what certain practitioners have used in theatres where tubes are tied. It's a bit of a skill to get right, and I would encourage you to look at the very good guidance from Comet and from Kids, which are transport teams from the Midlands, and there's a link to those documents. We like patients to have end-tidal CO2 monitoring. That's the gold standard, and that tells us if the tube is still in the right place in terms of ventilating the patient, but it also gives us loads of information about other things like cardiac outputs and how compliant the lungs are, and other issues in terms of respiratory pathologies and so on. So we'd like to know if the patient's got that on and prompt people to put it on if it's not there. Let's talk about breathing. So in terms of ventilation strategies, I think they've already been covered in the talk in terms of high flow and CPAP, etc. Embrace will use a Hamilton transport ventilator, and they'll put the patient on that as soon as possible, do a blood gas soon after to assess how the patient's ventilating on that different ventilator. I think it's worth saying before Embrace arrives, if you can hear a leak when the patient's being bagged or on whatever ventilator you're using, then chances are that we will need to change that tube if that's possible, do a bigger tube, and to make sure the patient can ventilate properly on transfer and going forwards at the PICU. And also consider, we don't need to be experts in ventilation, however, we'll always use PEEP in our ventilation settings for patients like this, and that might not be the case if you're an anaesthetic practitioner ventilating patients in theatre for a short period of time. So it's worth just making sure that PEEP is being applied to the patient, which will really help them from a respiratory disease point of view. To touch on circulation, we ideally need 2 points of IV access to move the patient, and that's because of the number of infusions the patients are likely to be on and the risks involved in losing access to your patient during transfer. If we think the patient's cardiovascularly unstable, might be fluid boluses, having some fluid boluses drawn up in 50 ml syringes really helps the Embrace team, if we can use them on transfer. And then we need to anticipate the need for inotropes. And again, if the patient's on inotropes, having them drawn up in 50 ml syringes will really speed things up and really help an efficient turnaround for the patient. If the patient's in a lot of oxygen, and we're talking about an FiO2 greater than 60%, for example, having an arterial line in situ will be really helpful, at least an arterial blood gas, because that really tells us what's really happening in terms of oxygenation for our patients. Thinking about the patient's disability, in paediatric intensive care, we use morphine and midazolam for analgesia and sedation, and that might be different to what adult intensive care practitioners use in terms of propofol, which we don't use as a continuous infusion. So that's worth bearing in mind, that these medicines might be a bit unfamiliar to certain practitioners. And again, I'll direct you to the Embrace drug chart, which we'll look at in a moment. And in terms of muscle relaxation, we'll use this to help ventilation, but also to make things secure on transfer. And we'd use either atracurium or rocuronium infusions to do that. It's really helpful if someone's assessed and documented the pupils and the patient's neurology prior to receiving any anaesthetic medicines. And here's the Embrace drug chart, and there's a link to this at the end of my talk. And I've highlighted where you can find the morphine infusion calculations that are required and the ranges that can be used. Note the difference between neonates and pediatrics in green. This is the midazolam for sedation, and note again the different strengths based on how much the patient weighs. And bear in mind, anaesthetic practitioners might not necessarily be used to using kind of this amount of midazolam as a continuous infusion, and again we just need to support them in getting those doses right and accessing the right strength of midazolam to use. This is where you might find the rocuronium for muscle relaxation, and in a different part of the drug chart we can find atracurium, which tends to be the muscle relaxation of choice for neonates, as it's not metabolized by the kidneys or the liver. Thinking about the patient's environment, ideally they'd have a gastric tube inserted, and we are aware that patients like this can get cold very quickly once they're being stabilized, so monitoring the temperature will be crucial. It's not essential, but a urinary catheter will be very helpful, especially if the patient's on lots of analgesia and sedation, as they might like to go into retention, and it's also useful for monitoring fluid balance. The patient's likely to be on maintenance fluids, and having them drawn up in 50 ml syringes would also help the Embrace team in terms of getting a quick turnaround. And think about, before we arrive with the Embrace transport trolley, is there space for it around the bed space? Is there anything that you can move out that isn't needed? And just to touch on some admin, have you updated the parents? Is the patient a neonate, and will a maternal blood sample be needed in terms of cross-matching blood at the PICU? Is there any expressed breast milk that needs to be transferred? Does imaging need to be transferred to the PICU? Has the patient got an ID band on? Have we copied all the necessary bits of paperwork, drug charts, lab results, etc.? And something to consider, a lot of patients that have respiratory deteriorations in kind of infancy are likely potentially to have been graduates from a neonatal unit, and therefore would have a useful kind of Badgernet neonatal unit discharge summary. So a quick phone call to the local neonatal unit and might provide some really useful information going forwards. Here's some useful links. So the STOP tool, the Safe Transfer of Pediatric Patients, is really useful guideline and paperwork for patients that aren't being transferred by Embrace. There's a link to our Embrace drug charts, and then there's some links there to useful guidance on that oral ETT strapping technique that I mentioned. Thank you for listening.
That's the end of the video. We hope you found it useful. If you have any questions or comments, please contact us. Thank you.